So at TIPPS, we thought that there are a lot of people who give the psychiatry DNB exams, and a lot of MD people also go on to give the DNB exams. And there is always this doubt that people have about how the exam format is going to be, and what are because DNB has a focus on OSCE, and that is something which is a little different from the MD exams. So we thought that as recently the DNB exams has concluded, and we have some of our academic coordinators who have given the exam recently. So we thought that it would be a useful session to have an experience sharing session wherein the people who have given the exams can share their experience of what were the cases, what are the type of questions asked, what challenges they faced, and that would help a lot of aspirants who want to prepare for the DNB exams. So I'm pleased to welcome our academic coordinators who are the panelists for today. So first we have Dr. Infant Beraro. So he is Assistant Professor of Psychiatry at the CMC Vellore Department of Psychiatry. Welcome, Dr. Beraro. Then we have Dr. Anoop Kulkarni. He is Neuromodulation Fellow and Consultant Psychiatrist at Manoshanti Pune, and he also gave the exams a couple of weeks back. And we are also pleased to have Dr. Srivaramangai. So she is a senior resident at the Lalitambigai Medical College in Chennai. Right. So for three of you, if you could switch on your video so that everybody can see you. Yeah. Hi, welcome.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Yeah. Okay, great. So all of you are also audible and visible. Right. So what we'll do is that we will put across some questions to all of them so that they can share their experiences. And maybe then after that, we can take questions from the other people who are listening to us so that they can get their doubts cleared from the three of you. So let's first start with let us know what the cases that all three of you got in the exam. So maybe Dr. Beraro, if you can go first and tell us what are the cases that you got.
Yes, sir. Thank you, sir. Thanks for organizing this, first of all, because this is very useful for each of the DNB aspirants, and it's a good initiative from the TIPPS team. So I would like to start with the cases which I got. Actually, I had got two patients. One was dysthymia. The second one was alcohol dependence. What they asked me is, in the first patient, they asked me to take only the history. That was the primary focus, and I was given 30 minutes for that. And my second patient, alcohol dependence, I was asked to do only the examination part, the whole mental status examination, and it was also allotted for 30 minutes. And they didn't insist in me writing everything. It is for our remembrance sake, we can write, it is up to us. But this is what they had asked. One thing I felt as difficult was the language was a barrier. I'm from Tamil Nadu. My exam center was in Kerala. My first patient knew English, so I didn't have any difficulty in my first patient. My second patient couldn't talk in English. He spoke only native language. I was given a translator, but the triangulation was difficulty for me because I need to tell the person who's there, and that person has to convey properly to the patient, and again it has to come in the reverse order. So I had some difficulty, and my patient also had some cognitive deficits. So he took time to understand what we are asking, and I found some time constraint in this aspect. That's it, sir, about the patients I got.
Right. So first was a case of dysthymia, and the second was alcohol dependence with cognitive deficits. Right. And you didn't have to take the whole history in either of the case. So one was history and the other was a mental status examination.
Yes, sir.
Right. So would you say it's different? It's not like a long case that you get in an MD exam.
Yes,
like
sir.
you get 45 minutes and you have to present a full long case. It's not like that.
It was not like that, sir. It was 30 minutes for each of these cases.
30 minutes each for two cases.
Yes.
Right. Yeah. Dr. Anoop, can you tell us your
Yes,
cases?
sir.
And also tell us where you gave the exam, which was the center.
Yes. So, good evening, all. So, my exam center was in KGMU, Lucknow. Similar pattern, like Dr. Beraro said, two cases. But the thing was, we were given 30 minutes each for each case. But the thing was, we were not told anything specific as to whether we have to take only the history or the examination part. So unfortunately, the time limit was 30 minutes, but it was expected to be presented as a long case only with the entire history and mental status examination. Uh, so the first case I got was an adolescent onset OCD with the comorbid bipolar disorder. So bipolar depression, basically. So that was my first case. So the second case was was a case of opioid dependence, who was also an injection drug user. So these are the two cases I got. So since it was not mentioned that we have to do specific history or MSc part of it, so we were expected to present it like a long case, like we do in our MD exams. So the main difficulty here was definitely the time constraint because uh, writing everything was not expected of us, but taking the entire history and finishing MSc and coming to a diagnosis and formulating a management plan all together in 30 minutes seemed a bit difficult. That was the main difficulty which I faced.
Right. So you had a OCD with bipolar depression and second case
Yes.
of
Opioid dependence. Yes.
Yeah. So both are actually typically long cases that will come in a
Yes.
MD exam, and 30 minutes is short is a
Yes.
short time. Right. But unlike Dr. Beraro's experience, you were not given any specifics about what was to be
Yes, sir.
elicited in this particular question.
So luckily, I did not have any language barrier because maximum patients are Hindi speaking in UP. So language barrier was not there for me, but the time management was really difficult. Uh, I mean, I ended up missing a few points here and there in history because of the time constraint.
Yeah. So Dr. Shri, would you like to share your cases and what was your center?
Good evening, sir. Good evening to one and all. So I'm basically from Tamil Nadu, and my center was at Vijayawada, English Hospitals. So what cases I got is the first case was OCD, and the second case was BPAD of 15 years old child. So for the first case, the patient itself is he was a previous IT employee, so he had good English knowledge. So it went on well. And as mentioned, I didn't have any specifications and all. They asked me to take as a long case. And for the first case, they asked me to present only the diagnostic formulation. And the discussion went on. The discussion took on for a long time, like where from starting from the management till non-pharmacological management, every aspect was discussed, including doses of SSRIs for OCD. So I think it depends on the individual examiners. And for the second case, bipolar affective disorder of childhood onset, I had difficulty. Translators were given for both the cases. I felt like the rapport with the translator was the one which we should focus on. So we will have some initial time before starting the case. So during that time, you can just get oriented to your translator. You can tell the plus and minus, like where they should focus, where they should where they cannot focus much in detail, and all that instructions you can give, like basic words and all. So I use those tricks. And for this childhood case, like I was preparing for the whole BPAD, they asked me to mention only the positive findings along with the timeline chart and all. But what happened was the differential diagnosis was the actual thing that was discussed for my case. They asked me like, what are the differential diagnosis? I mentioned everything starting from ADHD to conduct and everything, like childhood, since it is a childhood case. Then the examiner gave me a clue, like I'm expecting only one DD, which is like, which starts with the word D. Then somehow I remember this disruptive mood dysregulation disorder. And finally, the whole, the further discussion, it went on regarding DMDD only. So it was more of it. So whatever I've been mentally preparing for BPAD, all those timelines. So it was all kept apart, and the major discussion went on with DMDD. So that's how it went, sir. So translator is the orientation with translator is must.
Right. And is the translator, is it like a mental health professional or who?
No.
Is it?
For me, both they hired from some software company, I guess. Like they are totally non-medicals.
Non-medical.
Yeah.
Okay. Second case you said was a childhood onset bipolar.
Yes.
What was your first case? You said
OCD, sir.
OCD. Right. And you also got 30 minutes for
30 minutes for each case, sir.
Right. So that is something which is common across all the examination centers and format. So 32 cases and 30 minutes each. Right. So, Dr. Shri, can you tell us, like, okay, few questions you told us about differential diagnosis. But any like specific questions or viva questions that you remember that were asked for you?
For OCD,
for both these
actually,
cases?
my patient went on. I mean, he had 2 sessions of RTMS previously for OCD. So they were budging into RTMS, types of RTMS. That was also asked. And they also asked the latest, like N-acetylcysteine, all those things, like the full IPS protocol was actually discussed. And for non-pharmacological management also, they were asking about the steps, like what do you do apart from the what actual protocol and thing, how do you practically do in your patients? That was asked, sir. And for even for this, after telling about DMDD, I was asked about how do you differentiate it from mania, how do you differentiate it from oppositional defiant disorder. So that specific clinching points were expected.
Right. So the focus was one on treatment guidelines and second on differential diagnosis.
Exactly, sir. And dosage of SSRI for with perspective to OCD was also asked.
Right. And do you know whether the external examiners were the faculty of medical college or were they from private hospitals, or do you know that?
We didn't get that. I mean, after the exams, we just got to just have an intro section, but during the exam, we were not that much of interest.
Okay, so you don't know where your external examiners were from, etc.
No, sir.
Right. Okay. Yeah, Anoop, can you tell us about any specific questions that you remember that were asked for your 2 cases, the opioid as well as the OCD bipolar?
Yes, sir. So in the case of opioid dependence, mainly the questions were focused on the management of opioid use disorder in different phases, that is detoxification and long-term management. So it was more towards detoxification with buprenorphine. Buprenorphine, everything regarding the drug was asked in detail, including pharmacokinetics and the properties of buprenorphine in terms of whether it is a full agonist, partial agonist. So what happens if we substitute it with a full agonist, and what happens if we substitute it with a partial agonist, and about the ceiling effect, and what side effects what are the effects for which ceiling effect is not seen, and what doses does it usually come? And how do you manage patient with opioid dependence in the long term? And how do you manage the high-risk behaviors? And a few specific things were asked, like what do you mean by harm reduction, demand reduction, supply reduction, and these somewhat different things compared to the conventional questions. So along with that, since the patient also had a past history of cannabis dependence, he had stopped it for the past 5 to 6 years, but still he had it in the past history. So a few questions were focused on cannabis dependence. I mean, what drugs can be used in cases of cannabis dependence, and these aspects. And regarding opioid substitution therapy, that is a program which is run by the government. So that was also touched upon in the case of opioid dependence. So in my first case, that was OCD with bipolar depression. So questions were more focused on the management part. So since she was a young adolescent female, the aspects regarding the use of lithium in that age group were discussed in detail. So along with that, what are the second line and third line drugs that can be given in OCD? Because the patient had previous trial of, I think, fluoxetine up to 80 mg, which she did not respond. And the current set of medications were not known to the family members. So even though she was inpatient, they did not have any records. So those things were asked regarding the management if the first line or second line of drugs failed. So that was something which was asked. And ICD-11 diagnosis of both OCD and bipolar depression were asked in specific. So, and how is it different from ICD-10? So these were the main areas which were touched upon by both cases.
That was mostly focused on management.
Yes.
Right. And do you know your examiners, whether they were from medical college or private?
I heard that, I mean, two of them were from KGMU Lucknow itself. And one of the examiners was from AIMS Rishikesh is what I heard. And one of them was from Mumbai. So not really sure where from Mumbai. So, but they said that she was from Mumbai.
Okay. So most of the examiners were from institutes.
Were from institutes, yes. Yes, sir.
Right. Yeah, Dr. Beraro, can you share your experience of the questions, type of questions, and the examiners?
Yes, sir. So with me, as they told in the beginning, like for the first patient, they focused only on the way I presented the history. So they were looking whether I had got all the details which are to be covered in the history. That was focused particularly. And in the second patient, they asked me to focus on mental status examination. So they were checking whether I'm telling everything in a correct manner. The references they were asking me, like how the differences for checking the attention for memory, what manual we have used. So that they were asking me, the references were asked. And overall, they also wanted to take basic history for patient that was given for mental status examination. For example, in my patient with alcohol dependence, they expected me to check the patient's BP, weight, BMI, along with basic history like anybody there in the family with alcohol dependence and his medical history. So these were expected, which I didn't realize at that time. I focused only on the mental status examination, but they felt that for any mental status examination, it has to start from basic history taking. So that is what they expected, which I couldn't do properly. Otherwise, in the management, they were asking about first differentials. So for my patient, it was dysthymia. And I got certain cluster B personality factors also. So the discussion went about current personality disorder classification. And the first patient I had was around 20 years old. So discussion about childhood onset psychiatric disorders were also discussed, and they asked me to consider other differentials and to defend and support various diagnoses. And for alcohol dependence in the clinical examination, I also checked the signs of liver cell failure, which I presented. And they were happy that I presented that because that is the area they were looking for. They felt many people might miss it in the mental status examination. Overall, they stick to what they wanted from me. Like for history, they maintained only the history, and for mental status examination, predominantly MSc was assessed from me.
Right. And what is the time taken for discussion?
Discussion was around 15 to 20 minutes for each of the patients.
For each case. And do you present them separately, or do you present the same, like one after the other, both the cases? Or how does the discussion go?
it was two examiners who conducted the case discussion, and I once after completing one, I presented the next one to the same set of examiners. So it was in the same setting. I didn't go to the next examiner for it.
Okay, in the same setting, right? And do you know where your examiners were from?
So they're all from medical colleges from different centers.
Right. So they were from medical colleges and
Yes.
right. All right. So can you tell us about because the other unique feature of our DNB exam is the OSCEs. So can you tell us what is your experience about the OSCEs and what were the whichever how many OSCE stations you had, and if you can recollect what were the tasks?
Yes, sir. So I also felt task is very unique in the DNB exam. The first thing that happened on our practical day was OSCE, and it was a live one which will be conducted nationwide with videos on from all the centers. Around 12 to 13 centers were conducting it online at the same time, and there will be a person who will give instructions to the examiners and also to the candidates. Totally, there were 20 OSCE stations. Everything will be displayed on a screen through a projector, and will be given individual sheets for all the 20 OSCEs separately. For example, when the first question is displayed, it will be there for 4 minutes. So within that 4 minutes, I need to answer everything for that first question. After the end of 4 minutes, our examiner will come and collect it from us. And there will be 15 seconds given for the paper collection part. Within that time, another second OSCE will come up on the screen, and we'll be having all the sheets with us. So we need not collect it each time separately for the new OSCE. We need to be ready for the second OSCE, and each OSCE was carrying 5 marks each, and certain OSCEs were a bit lengthy. One tactic which I followed was I was looking at the last statement which they were asking. A big history would have been given, but when we get to know the last line, that will help us in answering the subsequent questions. So that was helpful for me. From my recall, I could say there were questions about areas of brain responsible for priming, procedural memory, events, and these were asked separately as a sub question. One picture of ECG machine was there. They asked about contraindications, what do you define by adequate seizure, and then relative contraindications, and different types of administering ECT. These were asked. And one clinical scenario was given about Parkinson's disease. And in that, they had asked about differential if the patient had urinary incontinence along with that with a new onset. So what do you suspect? The answer was like NPH. The question was framed like that. And they were asking about the management for all the clinical scenarios which were there in the OSCEs. One question was about negative expressed emotions. And one scenario was given about a dissociative disorder, and they asked, according to ICD-11, how do you diagnose? So they wanted us to know the exact term as per ICD-11. And clinical sign also they were asking, how do we demonstrate for the clinically, how do we demonstrate if the patient is having dissociative disorder? That who sign was asked, and questions on clozapine was there. I remember 2 or more questions were asked about male erectile dysfunction. That was given more importance in the last OSCE. Certain scales were asked, scales for suicide, and then psychotherapy techniques to be done for suicide. And one question was on most common predictor for suicide. Also, there were questions about famous studies done. I think I'm not very sure like what they asked. It was like a big description about the study. So like they asked, what is the study done regarding schizophrenia, in which Agra is a part where outcomes of schizophrenia was studied. So like this, the questions were a bit lengthier, and if we don't focus clearly what exactly they're asking, we may land up in wrong answers. At the end of 10 OSCEs, we were given 5 minutes break. We are allowed to use restroom if we want. We are given water also. And overall, I feel this will carry the most marks for the practical session. Around 100 marks out of 300 in the practicals will be from OSCE. So though we say it as a practical exam, we need to focus more on the theoretical aspect to clear this, I felt.
Right. And what is the total time for the 20 questions?
Yes, sir. 20 questions, 4 minutes each, 60
4
minutes.
minutes. So 1 hour.
Additional 5 minutes was given to us in between. Yeah, 65 minutes actually.
Okay. Right. Yeah, Dr. Anoop, can you share your experience of the OSCE?
Yes, sir. So most of the things have been already discussed. So what I felt
So did you also get the same
difficult.
questions?
Yes, sir. It was the same questions throughout the country.
Okay.
So
So it happens all
yes,
centers
sir.
together, it happens the
Together.
same. So there is a
So
uniformity in the OSCE.
yes, sir. Time management is definitely a challenge because even though we feel that 4 minutes is sufficient to answer the sub questions and recognize the ASCII, so since most of the questions were descriptive and most of the sub questions were framed like mention any four contraindications, that's entire question carried 2 marks. So 4 into zero point 0.5, that is 2. So writing wise, I mean, length wise, it was quite lengthy. That is one thing. So one more thing was the evaluation process. They had explained it before, which would be very specific. So if they have asked four contraindications or four things in any question, so only the first 4 points which were written would be considered for evaluation. So even if we write 5 to 6 answers, and out of those any four are correct, so those won't be considered. So the first four or first three, how many points which were expected in a question. So only the first of those would be considered for evaluation. So we have to be very quick in understanding the question and in writing the most important 3 or 4 points which were expected. So decision making plus writing down all those things. Is one difficulty. So there were, as it was said, there were 2 questions on male erectile dysfunction, and the sub questions were quite specific in that they had asked the subtypes according to DSM-5 and ICD-11, something like some very specific terms were asked. So that was one thing. So 2 to 3 questions were quite straightforward. They had asked about akathisia and management and these things. So one question on suicide was there, and one question was on clozapine. So there were a few straightforward questions, but largely I felt OSCE, even though people say that it is scoring, and I had spoken to people from other branches as well, medicine, pediatrics. So they had said that OSCE is the decider and it is quite scoring, but uh, uh, considering the specificity and the depth in which the questions were asked, it was not that easy, is what I felt. So few of the questions were straightforward, but maximum questions, even though the uh, diagnosis and these things were easy, but the questions, sub questions which were asked were quite difficult and were and required in-depth knowledge. That's what I felt.
Yeah. So they were like more
Yes.
application based,
Yes, sir.
reasoning based questions.
Totally. Yes.
Right. Yeah, Dr. Shri, would you like to share your experience?
Yes, sir. I think sirs have discussed most of the questions and the formats. It is the same for all over the nation. And the one thing to focus is seating arrangement. They will make you to be seated in rows according to the allotment thing. But if you're uncomfortable, you have to check whether the screen is visible to you fully, because for our exam there was no image based questions, luckily. If it is supposed to be some image based question, then we have to focus on the minute details. So it is always better to check to check if you're comfortable. If any this thing, you can inform the examiners and you can just shift your seat. And next thing is, please don't get stuck at a single question. Like if that question, because we will, for the first initial questions, will not be used to that speed and the way we answer. But I felt from fifth question onwards, I got into the flow. The next thing is, as sir mentioned, initially they will give you the papers and the whole, for all the questions, they will give you sheets. So you should, I think you have to write your roll number in all the sheets, and you have to keep it ready. And next thing is, as discussed, there were subdivisions for almost all the questions. We had subdivisions. So that gave some clue regarding the third question will give you some clue, and you can confirm your answer with that question. Like for example, I think for lithium or something, some tremor, something was asked, so I could relate. Okay, this is my. I can confirm my answer. And so speed and accuracy, and I think you should use only the first page of your paper, like whatever the paper sheet was given, only the first page you have to use. They will give all the instructions prior. And most of them were confused whether during OSCE session we have to submit our logbook. Some confusion for the primary DNB candidates was going on in my center. So there's nothing to be carried. Just have your neuro kit and everything. Like you don't have to carry anything specific. There's no logbook submission at the center where you are going to give your exam. So be comfortable and focus on your questions. For as said, it was more lengthier questions, and the answers were to be the speed and accuracy actually matters.
Right. Right. Any tips you want to give? Like as an MD candidate, how you need to prepare differently for a DNB exam, and any specific sources that you refer to
Sir,
prepare
I
for
am
DNB.
thorough with this tips notes only, because even for my MD exams, we prepared with tips notes, and we had this group discussions with tips notes only primarily. I think if we read tips notes, it is like 80, I would say even 90% of the questions you can be sure. Maybe the rest of the 10 might not be covered, because there will be more specific questions. Some questions which we have no clue in the world, like what are they asking. Some questions were like that. But I felt if there'll be specific OSCE tips, this thing PDF. So if you're thorough with that, I think we can easily go through the exams. That's what I felt basically.
Right. Yeah, Anoop, you have any tips, suggestions, reading materials? How somebody should prepare for a DNB exam specifically?
So for OSCE, I had referred to the tips notes only, sir. So few of the questions came directly from that, especially the one regarding ECT. So I had referred to only that. So I had not referred anything else. So considering the exam pattern now, so it might be helpful if they go through the basics of ICD-11 and DSM-5 diagnostic criteria. So these are the things which we can answer only if we know the criteria. So diagnosing it won't be difficult, and management also to an extent can be answered being post MD. So we'll have some idea regarding the management. So questions like diagnostic criteria, and one more question was there on specifiers in terms of DSM-5. So these are the things that need to be touched upon more, looking at the examination pattern. Apart from that, psychological tests and these things, it was given very much in detail in tips of keynotes. So which was helpful for my psychology table viva as well. So that OSCE notes plus some brushing up of DSM-5 and ICD-11 criteria should be sufficient. So apart from that, I don't think we can prepare much for OSCE because I felt it was quite unpredictable. It tested our overall knowledge rather than specific preparation for DNB practicals. So only OSCE needed some special preparation like this. Apart from that, for the long cases, for the short cases, it was similar to what we did for MD. So going through the basic psychopathology and history taking should be sufficient.
Also, can you tell us something about a table viva? Like how, what is the format for that, and what did you get in that?
So for us in our center, so after OSCE and cases were done, so in DNB practical curriculum, there is a specific section called as ward rounds. For us, they conducted ward rounds come table viva together. So for ward rounds, what they made us do was that they had a few patients. So it was more like assessing suicidality, assessing EPS, assessing obsessions, and assessing the diagnostic criteria for mania, and I mean some psychopathology like this. So patients were called in front of the examiners, and they made us interview them in front of them. So that was followed, and four examiners. There were four separate patients, and they made us assess single things. Like one examiner told me to assess suicidality, and subsequently the next examiner told me to assess the criteria of mania in a patient. And one more question was regarding EPS. And so followed by that, table viva. So we had mainly three stations like that, table viva. So one was psychology, one was drugs, and one was the neuroimaging. So the other examiner took a general viva. So where he asked questions from random topics. So there was predominantly forensic psychiatry. But there was no order to that, another table. So psychology questions were mostly based on the examiner asked me to identify all the tests which were kept on the table and anything special regarding the tests, like Bhatia's performance intelligence test was kept. And I was asked what is the unique characteristics of these tests. Whether it can be done in someone who has intellectual disability and specific things like this. And in Rorschach, I was expected to answer that it is a test of reality. So that was what the examiner was expecting. So psychology was more or less based on identification of the test and any special uh, properties or any special characteristics regarding that test, which makes it unique. So psychology was more of this. In drugs, I was asked to choose a drug. So based on that, based on what we chose, the questions were more or less related to the FDA approved indications and mechanism of action and side effects, management of side effects. And the examiner expected more of evidence-based answers. So how long do you want to continue a specific drug in a patient of bipolar disorder? And what is the evidence of it? Is it given anywhere or is it randomly followed? So evidence-based questions were asked mostly regarding the drug. Then neuroimaging, there were classical neuroimaging cases. Neurocysticercosis was the most commonly asked question to most of us. So ring enhancing lesions and how do you manage and what is the vector of transmission? Basic questions. Neuroimaging was not asked in that much detail. So only drug was asked in a more detailed way. And psychology was also more of superficial knowledge was tested. So we had these three stations and forensic. So one specific thing that was asked to most of us was school mental health program. So this was the one which was asked to all six of us. So that is something which was unique. So apart from that, MHCA was asked, POXO was asked. So these were the ones which were commonly asked. So the unique thing was school mental health program.
Right. Dr. Shri, would you like to share your experience of the ward rounds and table viva, how it was conducted?
So initially after OSCE, we had cases. After case discussion, we had viva followed by ward rounds at the end, sir. So for viva, we had four, it was divided into four. First was this psychology, where there were psychological instruments displayed, and we were asked to select any one and discuss in detail. Like I selected segment board test, and the questions which were following were also those which is actually in TIPPS notes. So that's how it went. And for TAT also, the whatever the already we had read from TIPPS notes was only discussed. And then following that, they discussed about since morning I had OCD case. So ERP in depth was discussed for me in my during my viva. The same examiner came for that viva part. So sir was asking about ERP and the other techniques in depth. So this is how psychology table went. Next one is EEG and CTMRA. For me, the examiner displayed like a series of EEG, and I was asked to identify, just name what EEG it is and what are how did you identify? What are the specific findings with which I can tell the diagnosis? And same for CT and MRI. One thing which I made mistake is for CT and MRI, I just directly told the diagnosis instead of saying this is CT, this is like T2 image, T1 image, and MRI. Like I didn't mention that the side. I didn't mention. I just told it is. Just told uttered the diagnosis, so that they expect us to tell in depth as if presenting in our routine exam. So that is one thing. And next is psychopharmacology. I mean, pharmacology, what happened is, my examiner had a PPT where a list of drugs, like he kept on changing the drugs names were displayed. We have to tell the mechanism of action and what is the indication. And he might also ask any contraindication or black box warning, something like that. Extra question will be asked. And in the same viva, along with drugs, they also discussed me about recent advances. And this journals were also discussed. Like they asked what is the color of Indian Journal of Psychiatry, what is the other journal that is being done by IPS. So I was clueless about that question. Then he gave me a clue. It is something related to psychology. Then I told it's of psychological medicine. So then they asked the color of the what is the front page color they were asking. And the final, the another viva was about general forensic. Everything was included. Where I had this, they mentioned they wrote in chits like POXO, some acts and all. They gave, and we have to pick a chit, and we from that they will discuss. So that's how it went. For me, initially POXO, I took about POXO. POXO, we used I told everything, but next chit which I picked was about some Mukta Abhiyan program was asked. I was totally unaware of it. Like I told them, sir, I have no clue about this. Then they were like, that's how that viva went, sir. So it will be divided into four, and there is no specific whoever is free. They told us to go to that viva. That's what they said. And following that, we had ward rounds. For ward rounds, four divisions were kept for ward rounds. One was about EPS, so we have to elicit. The next was about alcohol, motivation stage. I was asked to elicit. For that also, I had the examiner himself turned to be translator. They themselves helped us in translating. And the third one was eliciting signs of Parkinson's. And final was ADHD like mother and child were sitting, and I was asked to elicit the signs of ADHD, symptoms of ADHD from the mother. So this was my four viva rounds. One thing is, what they told me is like I asked the consent before doing an examination, like before for EPS, like before eliciting, I asked the consent, so that they appreciated. I think as for long case, as how sir told, we should not miss on the vitals and the general examination part. I think before any examination, it is always good to at least to tell, like, I'm going to perform this test. Is that okay for you? Just as a in a verbal communication, you can just ask. So that is how it went, sir.
And how much time in the ward rounds do you get for each of these tasks?
Ward rounds was the last part, and I was supposed to be the one before the last candidate. So it just went on randomly. I think maybe hardly 3 to 5 minutes for
3 to 5
each.
minutes.
That's it.
Okay. Yeah, Dr. Beraro, can you share your experience of your table viva and ward rounds?
Yes, sir. Actually, for us, there were simulated patients, and both ward rounds and viva happened at the same setting. So when we go and meet one examiner, both viva was and ward rounds will be done with that examiner, and we are done for the whole of practicals with that particular examiner. So like that, each of us need to attend four examiners separately. And for me, the first examiner was asking about historical aspects. So she was having pictures of all the famous psychological experiments and some famous personalities. And whatever we select based on that, we need to give further details. And she was also asking about the famous books written by those personalities. And that was the primary focus there in the first examiner. And we also had a simulated patient, like what I told. So I had catatonia eliciting. So they will look at whether we introduce properly to the patient and also to the examiner ourselves, and also about the procedure before actually doing it. And they also may evaluated whether we are making sure that the patient is not anxious about the procedure. So that was evaluated, and the examiner also told that I did that, and they appreciated that part particularly. And with the second examiner, he was asking to elicit knee jerk. Again, it is a simulated person, and that person actually got to know I was fifth among six people there. So he was very much cooperating, but I told him that this will not pain. I am carrying a stick like, but you don't get scared. So this was the instruction I gave. And examiner was particularly happy because on seeing a stick, any new patient will be very anxious. So it is our duty to tell them that it will not cause any pain. And I also told he need not do anything, and he just need to go with the procedure. So that went well. And the same examiner asked me questions about MRI and CT brain, both were there. As told earlier, they were expecting us to elaborate fully from what is it, whether it is a CT or MRI, what type of MRI is it, everything we need to say. And more than the diagnosis, they want us to tell the findings which we see in the imaging part. And the same examiner also had certain EEGs. So that was slightly difficult for me. I think we need to familiarize with all the famous EEG patterns, famous in the sense the peculiar EEG patterns. Like I was having PLED as one EEG, and another one was SSPE. One absence seizure EEG was there. So these are very classical ones, but highly confusing. So we need to prepare it properly, I felt. And my third examiner was focusing on child psychiatry. So psychological tests were also asked. Particularly the TIPPS OSCE was highly useful for me. It included all the psychological tests. And that's the strong recommendation I'll give for all the people who go for DNB practicals to do TIPPS OSCE. Definitely around 50 to 60% questions will come from that. And they also give a clear pattern on what are the things to be focused. And the same things were asked for me. I was able to do it. And in that examiner, there was a scenario for a POCSO. So they wanted me to explain to the one father, and a patient was a simulated one, and examiner acted as the father. So I need to explain both of them and convince them to make a complaint. And they will ask all their doubts, and we are in a position to clarify everything. And they focused on our empathy towards the patient and not being very strict, and giving them some time. In between, the patient was crying, so they look whether we are taking some gap and then asking the patient to drink water, whether they want a break or not, and then to continue the conversation. So these were expected. And in the final one, mainly drug related questions were asked. All the medicines were kept, and we were free to select whichever medicine or injection we want to discuss about. And I prefer, it is better to select the one which is not commonly taken by others, because mirtazapine was the drug which I took. And I realized that among the 4 people who went before me, everybody selected mirtazapine. So my examiner was a bit unhappy that why other drugs are not being taken by the candidates. So then I selected other drugs, and I was able to answer. So I felt they will feel that we are familiar with other drugs also when we take some other thing which are not routinely used in our practice. And there was an assessment on suicide for a patient who came with history of suicidal ideas, how to proceed. So that was assessed in the final examiner.
Right. Any other tips you have for those who want to prepare for the exams?
Yes, sir. The first major tips, which I already told, tips ASCII notes is must, which everybody has to do. And certain high-yield topics which I felt I had noted down. So these things which we focus, it will be helpful. I think EEG, brain imaging, close-up in criteria for treatment-resistant schizophrenia, various intelligent tests and psychological procedures, sections in the forensic medicine, historical figures, their contributions, and the books written by them, famous historical experiments, definitions in the mental status examination, and latest CPG guidelines for schizophrenia has come up. I expected that there would be more questions from that, but during my presentation in my long case, when I included that, examiners were happy. So I feel the latest CPG guidelines, at that point, we need to be thorough and present during when opportunity comes. And RTMS also, many questions were asked during viva for me. And the differences in ICD-11 and DSM-5, the specifiers, how the terms are being changed now. So these things we need to be aware. These are the high-yield topics which I would say. In theory, if we read past 5 years questions, that is more doable. But if we have more time, I would suggest to go ahead with 10-year question paper also. But there were many repeats in the previous exams, and the same happened to us. One thing we need to focus is on the recent advances. So that keeps evolving in all the exams. One good thing about theory part was the answers were very specific. So we need not write lengthy answers, and time constraint is not a problem at all, because whatever question they ask, they'll ask specifically. Write the side effects, uh, mechanism of action, and duration of treatment. Like that, specific questions will be asked, and they don't expect us to write anything extra, and will be evaluated only for the questions they ask. So these are my tips I could give for the tips onions.
Yeah. Thanks so much. So from what I understand, if I have to summarize, so I think the overall pattern consists of first the OSCEs, which is for around an hour, 20 questions. And the OSCE is more theoretical based, so it's more application and reasoning based, wherein some kind of a clinical question or clinical scenario is given, and then you're asked questions on that. And there, I think what came out from all three of you was the the timing and the accuracy is of these two things are important there. And after that, I think there are 2 cases that each of you have got, and each case you get 30 minutes for it. And there seemed to be some discrepancy between centers, like for Dr. Beraro, there was a very specific he was told what is to be done. I think Dr. Anoop and Dr. Sri did not have that specificity of instructions. But what is I think important there is that within 30 minutes you should be ready to take a long case, or at least the most important factors that is required in terms of for diagnosis management and formulation, etc. I think those things are one should be able for one should practice to elicit all that information in 30 minutes. And then there is a table viva, which includes neuroimaging, psychology, psychological testing, and drugs. And then there is ward rounds where there are usually around three scenarios where something is asked to be elicited. It could be either a neurological sign or some psychiatric sign or a short MSc demonstration. And so overall, I think the exam takes around 4 to 5 hours. Would that be half a day, or where does it go on for full day?
Around 7 to 8 hours, including the breaks, which break
7 to 8 hours.
Yes.
Yeah. So, but there is no, none of you got any pure neurological case?
No, sir.
It's only, I think, one demonstration of sign Parkinson or knee jerk.
Yes.
Right. All right. So to all the other listeners who are online with us, if you have any questions, I think you can, now's the time for you to ask the panelists. If you have any doubts you have, you can get it cleared. You can even put it in the chat box and we can take those questions. Somebody prefers to unmute themselves and ask the question, that is also okay. There's one question on what other topics to focus on in theory exams. So is there anything specific for DNB in terms of theory, which is different from MD exams?
So I felt, sir, more focus is given to topics like genetics. So in paper one, we had 2 questions regarding genetics only. So 20 marks out of 100 were from genetics. So genetics is something which is very frequently asked. So one more thing, as was discussed, was recent advances. So recent advances is frequently asked as well. Apart from that, nothing extraordinary out of the box. So most of the questions are from the expected topics only, which we prepare for MD. So nothing specifically that needs to be studied. So doing the previous year topics based on the importance and the number of times they have been asked. So that should be more than sufficient.
I think for any question, how you align your answer matters, sir, in theory. Like what is there, what are this question actually asked, and how do you frame your answer? So always just give at least 1 minute to think how to frame your answer, what you're going to write in your answer sheet. Because for the specific question, the specific pages are only allotted in theory exam. So for that, just frame, and as sir told, recent advances must not be missed. That has to be covered.
Correct. So recent advances seems to be something which is a recurring favorite topic or a recurrent topic in the DNB exams. But other than that, I think it is, the psychiatric theory does not change. I mean, the textbooks don't change. Textbooks are the same. So that way, preparation for theory is not so much different. I think the main difference comes with OSCE, because that is something which you are not usually prepared for. So that requires a little orientation. And as all the 3 panelists have said that they have benefited from the TIPPS OSCE notes. So maybe that is something that people can refer to.
Also, there is a PowerPoint regarding the psychological tests by TIPPS only. So I think it is there on most of the WhatsApp group. So that is also something which helped me a lot in psychology table viva. So that along with TIPPS OSCE notes, because TIPPS OSCE notes even has the order in which we are supposed to answer when it comes to neuroimaging, EEG, not directly moving on to the diagnosis, but in a structured way, whether it is a CT or an MRI. So which section of an MRI and what is exactly seen. So that is also given in detail. So referring to that, TIPPS OSCE notes is of prime importance. Yes.
Right.
I want to add one final thing for
Yeah.
people who are planning post-MD DNB. It is always better to write it immediately, because I did 2.5 years after my MD exam, and I find it difficult to recall all the theory back again. And it was like a second MD exam for me. I need to read all the theory back again. So in case if you're planning, try to do it as early as possible, because 2 sessions happen every year, one in June and another in December. We need to be very careful on when the dates are open, and please check the websites frequently. And whenever it is open, apply it as soon as possible, because the exam center also depends on the earliest of when you apply for the exam. And things to be kept ready will be your MD, MBBS registration and degree certificate, a recent photograph, bona fide certificate in case if you are working in a medical college. And also I found really difficult in making a live photograph, which was asked for me to upload. So it's a real-time photo which I need to take from my laptop. But at various position, I kept trying. There was some alignment which it was asking for. I almost did 30, 40 times and it didn't come. And finally, I sat and then I took a picture and the alignment came properly. So this I had difficulty. It might help some people if they have any problems with that. So that is my suggestion for everybody. Thank you.
Yeah, I think that's a useful suggestion, that, I mean, it's always good to take it immediately after MD, because you're fresh from having read the theory. So it becomes easier to give the exam. Right. All right. So if there are no other further questions, I'd like to thank Dr. Beraro, Dr. Anoop, and Dr. Sri for giving their time and sharing their experience. I think that this would be really useful for those who would like to give their exams in the future. So all the best for your results, and also best wishes to the other listeners who want to prepare for the DNB exams. Thank you. Thank you so much.
Thank you, sir. Thank you for
Thank
the
you.
opportunity.